So I'm in a tough spot here. All right. So thankfully I introduced myself earlier. So conflicts of interest, really just that electrocore, which was the group that provided the vagus nerve stimulator devices, did training, gave us the devices and the demo units. But they had no role in data collection, analysis, or interpretation. They still haven't seen the data. And of course, like everything in long COVID, it's off-label. So why am I caring about the vagus nerve, right? This is my daughter's contribution. She keeps asking me why I'm going to Vegas. So this was the start of it all for us, right? Because we're trying to take care of our long COVID patients, and we came across this pilot study that said, if you clip a auricular stimulator on, people's long COVID symptoms get better. And I saw this, and I was like, well, I mean, we don't really have a lot to offer people. Why don't we actually try this? So I called up Electrocore and said, can we talk about doing a trial? And they kind of said, yeah, sure. We got some devices and we got going. The background scientific theory for this, it kind of dredged up a whole bunch of stuff from the past, thinking about, clinically, we've always thought about things like POTS as being sympathetic hyperactivity. But then we started to think, is it really parasympathetic hypoactivity? And that's when a lot of our neurologists actually start to talk to us a little bit more and say, they have concerns about this being from the gut-brain axis, infection of the vagus nerve, kind of turning that part of it down. I'm not going to talk about neuroinflammation because Dr. McAlpine covered that so well yesterday. And, we've seen all the studies with the imaging showing that there is inflammation at the brain. The one thing I did want to bring up is this really recent article that came out talking about the mouse models where they found that an area of the brain responds to the body inflammation and kind of acts as a master clock for that. And this area, to give everybody PTSD, is in the nucleus of the tractus solitarius. And this is one of the areas that the vagus nerve actually hits. So all the previous data suggesting that, vagus nerve stimulation modulates cytokine activity may actually be related to kind of this whole process. So that's the background. So the question is, really simplistically, if we give people external vagal nerve stimulation, does it help their long COVID symptoms? So study design, we recruited 18 patients from the long COVID clinic. We're going to recruit 20, but I made a mistake of setting my inclusion criteria too tight because I really wanted to phenotype these people because, as we know, long COVID is heterogeneous, and the tighter we can clinically phenotype them, the more the stronger our findings would be. So we chose to include people with both fatigue and headache because at the time vagus nerve stimulators were really just being approved for cluster headache, etc. We ran into the problem that Dr. Pelusa talked about yesterday, where what do you do with a patient who acquires COVID while in a long COVID study? So we had to withdraw one of our patients from the study with that. So at the end of the day, we had 7 who completed and 10 who were assigned to usual care. I'm going to skip over that. Measurements, we chose to do questionnaires looking at both functional status, especially we looked at fatigue with a PROMIS F. We used a Compass 31 for the autonomic score. And in terms of labs, I'm pretty glad that I came after Dr. Antar because we chose to use DHEA because in our clinical practice, we weren't seeing much with morning cortisol. And then we did a cytokine panel and we did PET scan imaging. Really simple study flow. At 0 weeks, we got baseline PET scan, point-of-care ultrasound, blood draw, and did the questionnaires. Questionnaires at 2 and 4 weeks, blood draw at 6 weeks, everything at 12 weeks at study completion. The vagus nerve stimulator we used was the gammacore. Basically, just kind of feel for your carotid pulse, put it over it, and you turn the stimulation up until your facial muscles contract. The protocol I used was the one that is used for tension headaches, cluster headaches, sorry. So it's 6 minutes, 2 minutes on, 2 minutes off, 2 minutes on, alternate sides 3 times a day. So looking at demographics, N was 17. There were 11 women and 6 men, kind of matching the 2-to-1 ratio that we see in clinical practice. The treatment group did wind up being 4 women and 3 men, as the person who dropped out due to recurrent COVID infection was female. Age group was relatively consistent, and once again, we suffer from the demographic problems of Rochester, Minnesota. All the patients had at least 2 doses of COVID vaccination. Treatment arm was slightly more vaccinated, but it wasn't significant. And they were similarly sedentary or extremely inactive at the time of starting the protocol. All right, so results. Questionnaires. PHQ-9 improved by about 2 points compared to usual care at 0.3, but not significant. Then again, it's a small study, so maybe with more patients, it would have been relevant. GAD-7 actually improved by 0.3. Usual care worsened by 0.9 over the course of the 12 weeks. Promise fatigue. This one was significant. We improved by 5.6 points as compared to 1.2 with usual care. Of course, look at that really wide range on it, so results did vary even within the group of 7. Compass 31, that's the autonomic score, improved by about 1.6 points versus a worsening of 2.2 points. So definitely signals there, but didn't meet statistical significance as per the study. Labs. When we looked at kind of labs in correlate, morning cortisol did not change between treatment and controls. Most of the cytokines didn't change, IL-6, IL-7, VEGF. But 2 things did move. DHEA increased by 24 in the treatment group compared to a decrease of 1.2 in the control group, and that was significant. And that may have some bearing to kind of their overall improvement in fatigue if you look at the data from Dr. Antar and that higher max cortisol. We know DHEA is kind of your A1C of cortisol, so it does reflect that kind of overall improvement. And we found IL-16 decreased in the treatment group compared to the control group. I'm going to apologize that I don't have the PET scan data yet because that takes a lot of work with the neuroimaging lab, and I begged. Didn't get me very far. Patient feedback, 6 of 7 reported it was pretty helpful in managing their symptoms, no significant adverse effects, so very safe, well tolerated. And so, in conclusion, this pilot trial worked out well for us. We saw that vagus nerve stimulator was likely very effective. It was safe. It was well tolerated. We saw significant signal for fatigue, and we started to see some signal for Compass 31 as well. The lab markers do kind of give us targets for things we can look for when we move towards larger trials. And that's really where we're trying to go, is larger trials and thinking about patients with long COVID. Do I think it's going to help every single patient with long COVID? Maybe not. Fatigue, dysautonomia, based on the clustering of those 2 in that excellent talk this morning with the statistical thing, I don't know what to name, with the bubbles that go to each other. Those 2 cluster with cognitive dysfunction, so I'd probably target cognitive dysfunction as well. And I probably would take some of the things that we did out as endpoints. PHQ-9 and GAD-7 probably aren't going to track as fast. The post-COVID functional status didn't track. And I think that I probably wouldn't use cortisol in the future. So I'm going to get you guys to lunch on time.